that people describe the
yeah. Okay, I'll make a start, and just to recap, because this seems a long time ago now, wasn't it? But we were talking about acute treatments and the idea of non-specific versus migraine-specific. And this is because we have this hypothesis that of the trigeminal nerve and knowledge of serotonin receptors and knowledge of the neuroactive peptide that's released by the trigeminal nerve. And if we consider these 4 phases of the attack, we call it a migraine attack, the pain comes along with the associated symptoms, nausea, photophobia, phonophobia, and this is occurring at the same time as the pain. And that's why these migraine-specific medications are very powerful. And many people are helped. Now, there'll be some people that can't tolerate them or don't like them, but these have provided relief for many migraine sufferers. And so these are the ones that we call migraine specific. So you wouldn't use these. These are very targeted medicines, if you like, for migraine or vascular type headaches. We wouldn't be using them as non-specific or just masking the pain. So that was the distinction of this very special kind of pain, because we know a lot about the pathophysiology. And I did it in a kind of a reverse order, but if you notice here on the notes, the ergot alkaloids were the first generation of migraine specific, and they have a lot of side effects. I got going just because, as always, I've got a lot of notes to talk to you about between today and tomorrow. So, but we're just recapping what we went over. So historically, before the 1990s, it would have been the ergot alkaloids that were considered migraine specific, but they're very, very powerful abortive agents. They cause very powerful vasoconstriction. And so the triptans came and really have dominated for about 30 years. And what we're seeing is now a lot of emphasis or interest in new sort of first-in-class, still a lot of work in this area by multiple pharmaceutical companies. And so we kind of got to where we talked about why lasmiditan, so ditan has this new suffix, the sort of a pure 5-HT1F agonist, and is not supposedly constricting. This was a new approval. And then where the landscape has really changed is that finally all this basic science, all this research on the CGRP, calcitonin gene-related peptide receptor, and knowledge of the ligand that's predominantly released by the trigeminal nerve has given us a whole cluster of new approvals in this space. But what we've been talking about up till now is mostly the acute or abortive treatment of migraine. So you'll hold a prescription for a limited number because these are all that meant to be used to stop the attack as you know it's happening, and they're abortive. The idea that you can stop it from getting worse, because untreated, a true migraine headache or some of the worst kinds of migraine headaches could last 3 or 4 days if they just have to kind of take their course. So that's really where we were up to. We talked about the idea the first new things to come onto the market for acute treatment were these small molecule GPANs, so calcitonin G related, so it's a real mouthful, isn't it? So small molecules interfering with the signal transduction at the level of the ligand for this receptor. And then we've got one strange one where they managed to get approval for, and it's an oral disintegrating tablet, which comes and it's packaged. Now I was looking into this, I can't see that the dose is any different. So people get a limited number in a blister pack. You've got to be careful when you open it because it's supposed to be orally disintegrating, but it's the only one that's approved for use as an acute and a preventative small molecule antagonist. So I'm just going to emphasize the idea of small molecules. This is a chemically derived versus the biologics that we'll talk about towards the end. So this particular signal transduction cascade is sort of, for the first time now, crossing over. We've got a lot of approvals of biologics as preventatives, but up till now we've been talking about what makes these migraines specific. So just to, hopefully this slide helps you keep that straight, because if you've got a template of how to think about it, I think this is the easiest way not to get overwhelmed with this area where there has been a lot of drug development and new things coming onto the market and new approvals. So we talked about the idea for many people that have a history of cardiovascular disease or ischemic stroke or any kind of worry that there is vascular issues, then this really meant that the triptans are contraindicated for all those individuals. There was a large area of unmet need, and this is a space where you will see some of these combination analgesics, where we've got caffeine along with a barbiturate or an opiate, so often codeine. So these are some of the common names, but we've got a lot of, especially for people, a lot of combination analgesics that would be the first line if somebody suffers from any kind of cardiovascular disease and you will be worried about giving a triptan. The other, and we talked about medication overuse, but what I'd like to do is now move on to the complex or atypical migraines. And so this was sort of a catch-all phrase, but the idea, meaning that if you don't fall into the typical migraine, but these individuals have a very severe kind of aura. And the thinking is that the unusual heterogeneity of the aura and the long-lasting effects of the aura, which can be quite frightening if you first experience it, it almost will look like a stroke. But in an emergency room situation, after scans, and if a stroke is ruled out, often this aura will go away and then the headache may or may not develop. So sometimes people might have the frightening aura, but next time they'll have the aura, then the headache. And this becomes what's known as the atypical. And this is also a place where those triptans were contraindicated. Now, in theory, these new approvals should change this space for people suffering from atypical or complex migraines. The thinking is that what's happening is it's a vasospasm, and that's occluding the blood supply to some of this brain area that may be involved in speech or vision. And this is why they present as having stroke-like symptoms. And maybe this is where the first line for now, the cheaper one, is going to be the combination analgesic. That's probably, they would not be given a triptan normally. And we don't know yet what's going to happen with lasmiditan and the CGRP. Who knows if they're going to be efficacious, but for now, these ones I would imagine are fairly cheap. So the knowledge of the atypical migraine and the stroke-like symptom, it's worth just thinking about this condition. So some of the idea behind what's causing the complex migraine comes from people who suffer from hemiplegic migraine. Does anyone know anyone who has hemiplegic migraine? No. So sometimes I've met a few people who who do, and it literally you become paralyzed, it's a very severe kind of migraine where the aura is really, and I've put in bold the key things. So it's a temporary, so it's usually unilateral because it's one-sided, and you think that one of the trigeminal nerves is beginning to be inappropriately activated, and it's really dramatic muscle weakness. So their aura is paralysis down one side, preceding the pain. So this tends to be familial unless you're the first one in your family to then realize you have it and start the next generations of people with hemiplegic migraine. But this has been one pathological mutation which causes hemiplegic migraine in families, is a mutation in one of the voltage-gated calcium channels. And so therefore we could say that this kind of migraine is actually a channelopathy. And of course, as we think about pharmacogenomics and sequencing and patient information, if you had a reason to suspect your family suffer from this, then you might get a true diagnosis. But it's a little bit like we never know really what causes your particular migraine. But this gives us the idea that some of them might be channelopathies. That's why some individuals will be more predisposed to any kind of migraine, because we don't really know what the triggers are. So a lot of work in this area has more or less concluded that many people with hemiplegic migraine there can be a cluster of mutations in that calcium channel causing hyperexcitability, and when in their aura they will get a paralysis. So this often is alleviated with calcium channel blockers, so things like verapamil. So you can see that in the whole scope of migraine, to help these individuals, you might be looking for something that's very targeted. So calcium channel blocker, because in this case, there's a very good chance it's a calcium channel mutation that's beginning it. But hemiplegic migraine has been around for a long time. It's just, I think that we're now getting more, the work on this kind of migraine helped us understand complex auras or atypical migraines and these stroke-like symptoms that can present. So once somebody is diagnosed as having an atypical or complex migraine, they're more likely to have those kinds of migraines. They get an unusual aura, and their migraine will tend to follow this kind of pattern. So, but the key is it should be reversible, and a lot of emphasis on knowing your triggers and keeping a headache diary and trying to reduce the frequency, severity, or duration of these kinds. So we've got that's the end of really the main migraine-specific treatments. And now what I have in the notes is the idea of anti-nausea medication. So we know that the trigeminal nerve, when that's activated, some individuals are very troubled by intense feelings of nausea or mechanical vomiting as the pain arrives, and that makes it difficult to take an oral medication. But this is why you might, in some cases, have a patient that gets prescribed an anti-nausea medication to be taken at the time of the migraine. So it's really as needed, and it's not going to help the migraine headache pain, but it's going to help the nausea that comes along with it. So that's where the anti-nausea medications would fit in. And you'll do this as a separate topic next term, I believe. But really, this is just to help control excessive nausea and vomiting associated with the headache, which is going to make you feel miserable if this is happening as well. But think of it as an add-on. You probably are also going to be prescribed something for the pain of the migraine, but this is just going to be added on to help with relief. But of course, it's not going to target neuroactive peptides. It's not going to target serotonin receptors. It's just there as an add-on. Some people might also be given an anti-inflammatory prescription, like dexamethasone, or if someone's really suffering, you might decide to give give dexamethasone just to try and reduce the inflammation. Because if you think of the inflammation at the level of the cerebral vascular in the meninges, that itself can cause a lot of pain. So this could also be but different mechanism add-on medication. So it is a complex pharmacology in this area, quite specialized. But what we're going to do now is just think about prophylaxis. And this is where the idea of thinking of it a little bit like anti-epileptic medications, where the goal is different. So preventative or prophylactic medications for migraine sufferers are there to reduce the frequency, severity, or the length of a migraine attack. There's actually quite a list of different mechanisms of action, and sometimes it's not clear exactly why they work, but all of the medications that can be prescribed for prophylaxis have met demonstrated some kind of efficacy. And so sometimes people will go through different ways. One isn't working for prophylaxis, as a neurologist might try you with a different mechanism, but the goal is quite different. And the theory is, or the rationale is, that over time, if you don't let headaches emerge and you don't have this acute, severe kind of headache, that will just reduce the inflammation, reduce the triggers, and just allows everything to stay under a threshold where you wouldn't experience the pain. So you see the goal is if you have less of them, if they're not as severe and they don't last as long, then that's enough to show that it's efficacious and these can help prevent. So we call preventative, prophylactic. I'm trying to use the general terms that are used. Sometimes you'll only hear one, but prophylactic, preventative. But you shouldn't use them to treat a rebound headache, something that's causing from medication overuse. So this prescription for preventative medicines, very different plan, different idea. They're not going to necessarily treat the pain, but the goal is to reduce frequency, severity, and duration. And so you can see here's my list. So really, if there's a 50% decrease versus placebo, these are things that have been approved as preventative treatments. So some people take beta blockers or antidepressants. So propranolol, these are quite common. And some insurance carriers require you to try different things until you come to these other preventatives as well. So it can feel complex because you're not quite sure where the patient's up to in this journey of trying to show that these can be prevented. But this is a sort of prophylactic journey and at the same time they probably have some medication to try and acute or abort when there is a full-blown migraine. Some people use antidepressants, and then this is where we've also got neurostabilizers. So some of those medicines, as anticonvulsants or were developed, you'd actually use them or prescribe them to just, they have efficacy as prophylaxis. And then we've got calcium channel blockers. So there's good evidence if you have a channelopathy, or maybe you don't know, it's not been defined properly, but some people will find relief with verapamil, and certainly this comes from the hemiplegic migraine sufferers. And now we have these newer, the CGRP antagonists, and these are the monoclonal antibodies. And so they've come in the last few years. I believe they're still expensive, but these have a very long half-life. So some of them, the idea is you would go and have maybe you're taking them every few weeks instead of every day. So different kind of medication. And then we talked about some of the small molecules that have also been approved for preventative medicine as well. So in the space of antagonizing calcitonin gene-related peptide. Then right at the end, I'll just mention botulinum toxin, Botox. So this is also an FDA-approved treatment for prevention of migraine headaches. And then a lot of people try changing their diet, vitamin supplements. And these are all things that usually at this stage, someone is probably working with a neurologist and sort of trying to, over time, improve the outcomes for people who have really suffer from debilitating headaches. So these, as far as I can tell, there's still 4 of them. These are, and your clue with the, again, is that you're probably talking about monoclonal antibodies in other areas of medicine, but just from the name, you can't often tell from the trade name, but from the true name, there's some, these, you can tell it's an antibody, and they have been developed to the receptor and to the peptide. So you could functionally antagonize the ligand or functionally antagonize the receptor and still achieve the same outcome. So they can be, I think it's about once every like weeks to months. So I think there's different half-lives, but these are targeting the receptor, this one's targeting the ligand, another one subcutaneous, and then another. So actually three to one, most of them are targeting the actual neuroactive peptide. And so what they're doing is functionally antagonizing it. And I've got a picture, so just to remind us, this is that same diagram. This is a receptor complex. And we can either antagonize the receptor with a small molecule or with an antibody, and or we can tie up the ligand itself with an antibody. So these are, we're seeing them emerge for acute, but a lot of the antibodies for prophylactic. And then this is just another picture. There's been a lot of reviews in the last 2 or 3 years. So if you're particularly interested in this area, I've tried to give you some of the some of the references if you want to follow that up, but a lot of information, and this is showing you the receptor in probably a little bit more of a topological arrangement. So it's a 7-membrane, the actual receptor has got 7 transmembrane domains, and then there's this other more simple spanning separate protein, and then on the intracellular side we've got a complex as well. So this is the idea that here would be our trigeminal nerve, calcitonin gene related peptide being released from this nerve, and if we have administered an antibody to the ligand, this would be working at the synapse to sort of mop up or functionally bind to the ligand, so that it's not available to interact with the receptor. We can also design an antibody. It's probably been a race of different companies making these things, generating these, and then the race to get to an approval. And this would be the concept of the monoclonal antibody actually binding to the sort of tying up that ligand binding domain. So now that you've caused a functional antagonism at the level of the receptor. So I thought that was quite a nice diagram, because it pulls together a few of the things we've been talking about, the importance of calcitonin gene related peptide in this signaling pathway as part of the migraine headache. So if you can take or reduce the signaling for weeks, now you're at a situation where there's less likely that neuroactive peptide is going to cause vasodilation or cause that neurogenic response. So this would be the site of action of the monoclonal antibodies. This is actually just the same summary. I wasn't quite sure which one to use, so I've given you the same. Maybe you'll like this picture too. Again, here's the neuroactive peptide, here's the receptor complex, and this is just showing you the idea of where these targets can be. Here's the trigeminal nerve, releasing calcitonin gene-related peptide in the middle. And normally this could bind to the receptor and causing vasodilation. So you can stop this vicious cycle that's really not very useful at all, because this causing an overactive or too much of a nociceptive response. So on this diagram, if we go from the left, here's the idea of an anti-CGRP receptor antibody, now functionally antagonizing here. Here is the idea of a triptan working presynaptically at a serotonin receptor that's on the trigeminal nerve. And then here's the idea of a small molecule that's chemically derived. So the idea of a little diamond, it would be the GPANT, a chemically derived. And above it, here's the idea of an antibody just functionally antagonizing the ligand. So also another good summary, but hopefully that helps you fit these different small and large molecules. So a lot of pharmaceutical companies are calling these biologics large molecules to differentiate in your mind that, you know, they're going to be generated in a different way in terms of stability and storage. When you're dispensing them or dealing with them, it's going to be quite different than a more like a chemical, a small molecule. And again, this is just to reinforce in the field of migraine headache, we have examples now of biologics being used. And here again, the idea again of here's the vessel and the trigeminal nerve, and the site of the problem is this signaling here. So here's our calcitonin gene releptic peptide causing these vessels in the cerebrovasculature to dilate. So this is our vascular hypothesis. And so we've got, again, the same idea. The idea that it's blocking signal transduction downstream via an antibody or an antagonist. So in theory, you could switch. Some people might not tolerate the antagonist, and you could try them with a biologic. But at the moment, they're all quite new. So let's see if they all stay, if people use them all equally well, or whether it's better to target the ligand, not the receptor, or whether the Nurtec one will have an advantage with the only one so far that's managed to be approved as a preventative and an acute, but at the moment still quite expensive. Yeah, so a few slides there that show you the same thing in a different way, really. So just to go back to, and really here, my reason for showing you this slide was the idea that botulinum toxin has been approved for a long time as a prevention for migraine headache. So going and this is administered usually in a neurology office, as far as I can tell, and nurse practitioners are trained on where to give the injections. And there are it is a very defined area across the face, the side of the head, and then the back of the neck. And in this case, we're targeting the neuromuscular junction. So this is the idea maybe of a tension type headache or muscle triggering migraines. And this has been recognized for a long time. And the mechanism of action of botulinum toxin, which you probably covered in autonomics, but just to this on the right-hand side, the idea that what is happening here is that botulinum toxin is directly interfering with the process of synaptic release. Do you remember we talked about the snare proteins and the signaling that where the vesicle docks with the presynaptic membrane to release acetylcholine, if we're talking about the neuromuscular junction. And so this is really the site of action. So completely different. It's the use of Botox in a therapeutic setting for prevention of migraine. I don't know if it helps your wrinkles too, but this is an FDA-approved mechanism working at the level of the neuromuscular junction to change vesicular release. So just a few notes about that. So right at the end, I just wanted to talk about cluster headache. I've kind of ignored it a little bit, but I think it's getting more and more recognized. And the interesting thing about this kind of headache, it's actually, we're starting to learn more about it. It is considered a vascular headache, so you might get a lot of crossover in the medications, in that some individuals will find relief, but it does have its very own issues. So a lot of people can elect for, or it's common to have oxygen therapy as an abortive therapy for this kind of headache. And then the prophylaxis includes, corticosteroids, verapamil, lithium even. So little bit of a crossover, some overlap, but definitely recognized as a separate kind of headache. Remember, it was a separate kind of primary headache disorder where the pain comes from behind the eye. And it can be primary or secondary to other headaches. And people, if you don't treat this kind of headache, the individuals can end up having a chronic pain syndrome where it goes to become a chronic daily headache. So cluster headaches, it turns out more men suffer from them than women. So there definitely is some interesting pathophysiology, but appropriate to treat it because you want to avoid the chronic pain condition known as a chronic daily headache. So it's estimated that if we go to this next kind of headache now, a significant number of people suffer from a headache every day. And doesn't seem like a migraine, it doesn't seem like a tension headache, it's just every day they wake up. Sometimes it's become this kind of, it's changed or morphed into a different kind of pain syndrome. So that's why it is appropriate to treat headache, understand what the kind of headache it is, so that it doesn't become something more complex and chronic, which is probably even harder to treat. So the very last, I think, I'll spend the last 20 minutes getting a start on the next packet, but really what I wanted you to realize, or what we've done, is talk about very specific kinds of headaches. So there are probably even more than 6 different kinds of headache, but really what we've done is walk through 2 primary vascular headaches, migraine and the cluster headache. Attention type headache is also a primary headache. Medication overuse headache is a secondary headache through using too much medication to treat the original headache. Chronic daily headache becomes a chronic pain condition where the sufferer has a headache every day. Now that can be maybe a little bit hard to distinguish from the medication overuse headache. So understanding the patient history and what they're taking. But this becomes a very complex pain syndrome. So neurology specialists will probably see all these. And I just put this back. We talked about headaches for other reasons, a stroke or an ice cream headache because of a cold shock. A caffeine withdrawal headache is also a different kind of headache. So where you're used to having caffeine on board, slight vascular effect of caffeine, and now you haven't had it. So stimulatory effect, people get used to having caffeine. If you take it away, often people complain of a throbbing headache based on, but you can tell that this is a different headache. Your headache is because of caffeine withdrawal, a substance that's habitually consumed by individuals with its own pharmacological activity. So hopefully, does that help navigate through headache? Yeah, great. So thank you so much for helping. I'm going to switch now to the last packet, and what we'll do is just start to talk about, I'm going to cover 2 topics. The first are the drugs used for the treatment of ADHD, attention deficit hyperactivity disorder, and I think the best is almost talk about them at the end, because some of the same group of compounds or structurally similar compounds are also things that we know fit into the topic of drugs with abuse liability. So along the way, all term, we've talked about things that are abused, drugs with abuse liability, because they, on some level, impact dopaminergic signaling in the nucleus accumbens, so ventral tegmental area, that other set of long projection axons that are dopaminergic, completely spared in Parkinson's disease, but are the neuroanatomical region for abuse of medication. So we have a lot of, often coming from natural products, which have taught us a lot about neurochemistry and neuronal wiring. These have become very useful tools as we try to help people recover or help treat what is a chronic disease. So that'll be most of tomorrow. But before that, because we're going to talk about amphetamines or stimulant-like drugs, which are going to work at the level of the dopamine transporter, we'll first, as a separate topic, discuss the treatment of ADHD. So this is just showing you a cross-section of the human brain. So that this individual, I think all my brains are looking to this wall, aren't they? Looking that way. And so here's our prefrontal cortex and some of these landmarks with the cerebellum at the back that we've been thinking about. And really, I think the best working model of how to help people with ADHD is the fact that there's been a lot of research and continues to be a lot of research because it's a huge area of unmet need. But a lot of the attention is focusing on the prefrontal cortex, and because this disease is really considered a neurodevelopmental condition, and where we've got changes in the development of how the prefrontal cortex communicates with other parts of the brain. So we know that these regions of the brain don't function in isolation, but a lot of the current research is focused on the prefrontal cortex because this is the area that allows us to integrate our thoughts, our feelings, allows executive function, making judgments, paying attention, making decisions. And this is the area where we believe that when we take the large class of drugs that are prescribed as stimulants for the treatment of ADHD or to help alleviate the symptoms, the site of drug action is in these brain areas. And so just a few facts about it. It's very common and does require special healthcare needs. It develops in childhood, and that's why it can be very difficult, or maybe there's reluctance to diagnose and start treatment because it's a neurodevelopmental condition. But many people aren't diagnosed till later as adults. And we do know that if it's untreated, a lot of the studies suggest that it does lead to poor outcomes. And so the diagnosis is based on behavioral symptoms, and often the children at a young age, and this is why it is difficult because we're talking about preschool age children, but they have difficulty usually in multiple settings, at home and at school. Many, if not left untreated, or it might manifest as a learning disability or have difficulty reading. So these are the kinds of warnings or concerns that would be where people come to the decision of having a diagnosis of ADHD. But you can see it is difficult because we've got quite a large age range, and you might have mild or severe cases as well. So just to mention, because autism and autism spectrum disorder can share features and can coexist, but we consider these different conditions. So my pharmacology today is really just focused on the treatment of ADHD, but because there is some overlap in neurodevelopmental conditions, I just wanted to mention that. So at the moment, we recognize 3 subtypes. And so in the Diagnostic and Statistical Manual of Mental Disorders, version 5, we recognize it as either predominantly inattentive, predominantly hyperactive and impulsive, or a combination. So we're getting better at the diagnosis and better at recognizing subtypes of ADHD. And the important thing to realise that we don't always have to reach for pharmacology. There is a lot of work on non-pharmacologic treatments, but pharmacology is my just because I'm pharmaceutical sciences, I'm going to tell you about the pharmacology. You'll hear about, but this is should be a balanced input and a team approach with experts trying ways to help that don't involve chronic or long-term treatment with what is a very powerful group of drugs. And this is why there's you probably will be asked your opinion about it. And I think that I just go back to the fact there's no evidence that people that are treated for ADHD with these stimulants have a history of chemical dependency or become addicted to these drugs. And that's because the pharmacokinetics is different. They don't produce the high that would happen if, now that's not to say these people might be approached to sell them or divert them, but if used appropriately, it's ethical to treat ADHD but they are often the same chemical that if you were to crush the pill, take it differently, take more, take it when you don't have a diagnosis of ADHD, it will certainly give people a feeling of euphoria, or people will find it pleasurable for a different reason. So it will cause pleasure and euphoria, because if you think of our basic things that are euphoric or enforce pleasurable sensations or helpful, will tend to be people will habituate to them and seek them. There'll be drug-seeking behavior. But if we just stick to how they're supposed to be used, there's no evidence that these will lead, and it's actually worse to not treat the ADHD. So what we will divide this topic into is the stimulants, and these are the amphetamine-like chemicals, versus the non-stimulants. And we've got about 4 FDA-approved non-stimulants, and there's still interest in this arena because there is so much reluctance. Ideally, it would be much better if we had medications that didn't rely on the amphetamine, methamphetamine-like structure, because they're all very similar in terms of the mechanism of action. So, but we'll first talk about the stimulants, and the idea, it's almost counterintuitive, but when you give stimulants that have got the appropriate pharmacokinetics, they will, and you think about it, where we're trying to, the site of drug action is the prefrontal cortex. It's not the nucleus accumbens to treat ADHD. So think of what you're trying to do with the drug. And when in the site of drug action will tend to reduce hyperactivity and impulsiveness and improve the ability of individuals to focus. So this is the intended site of action when you're giving it for ADHD. So sometimes we are concerned with cardiovascular, because any kind of stimulant or of this nature, you would be worried about just peripheral cardiovascular toxicity. So there could be some screening to make sure that cardiac function is normal. But the site of action for the stimulants is the prefrontal cortex, those areas of the brain that are required for paying attention, making decisions, focusing, learning to read. And so I think that the easiest way to think about it is that there's a class of chemical structures that are going to look very similar, but in bold, I've picked out the ones that have approvals or are associated with ADHD. So amphetamine, dextroamphetamine, and then the levorotatory form of it, methylphenidate, and then there's a lisdexmethamphetamine. On this slide, I've not bolded the ones that have no medical use, even though structurally they're similar, but these would be two no medical use, and they're, for example, methamphetamine Schedule 1. But here, these are mostly Schedule 2, so we recognize structurally they're very similar, but we've got a subset of the amphetamine-like stimulants that are prescribed for the treatment of ADHD. And what we're trying to do in these areas, it's dopaminergic and noradrenergic transmission in the prefrontal cortex. And so these in bold are used to manage the core symptoms. So people are less distracted, they're more alert, they're able to pay attention, reduced impulse control. So you can see why if you wanted to study, or either there are reasons in your life why you might why these are diverted on campuses, and people have studied this because they definitely are known for this pharmacology and in the prefrontal cortex. So there's drug diversion for other reasons because of their pharmacology. Some of this class of drugs are also used to treat narcolepsy, and that's an area where we're kind of starting to see a few other things. You remember the orexin receptor signaling, and they've also been approved or have been used for the short-term treatment of obesity, although that landscape's changing pretty quickly at the moment too. So let's see if this still is true. So we've got a lot of different pharmacology being used for obesity at the moment. So the very cool thing, which I'll just have time to introduce. So here's our dopaminergic neuron. And you're familiar with the idea of a drug such as cocaine, which is an inhibitor of the dopamine transporter. So here's our dopaminergic synapse. And here's dopamine release causing an increase, and this was just taken from, this is Katzen, but I think there's similar ones in other texts as well. So when we release dopamine, we see an increase in the synapse. The reason that cocaine is such a well-behaved drug of abuse, so powerful drug abuse, that it inhibits the dopamine transporter and then allows greater amounts of functional dopamine in the synapse. And so this is the action of cocaine at the dopamine transporter, but cocaine stays outside of the cell. It is a non-transported inhibitor. So if you think of the transporter as a channel and dopamine is the substrate for the channel, cocaine blocks the channel or is an inhibitor, and itself is not transported, just as the SSRIs or the SNRIs block the function of transporters, but Prozac or things like that do not get inside the cell. They stay on the outside. They're non-transported. They're not substrates for the channel itself. It just recognizes the neurotransmitter. In contrast, the amphetamines are considered to be are substrates for the transporter. So on the right-hand side, we're looking at the same dopaminergic synapse. So there's a lot going on. But if we take it from here, here's dopamine being released into the synapse. Amphetamine actually is a substrate and can get inside the cell. So the amphetamines are transported substrates and can accumulate inside the neurons. So you notice here, it's a little bit subtle because the dopamine is in gray. The amphetamine is shown in this orangey red, but you're seeing it inside. It's also a substrate for the vesicular monoamine transporter on the vesicle. So this is why you remember the idea of a reserpine-like effect where things make the vesicles leaky. What happens is because this vesicle is leaky and not concentrating dopamine, you've got dopamine increasing in the synapse. It's not where it should be. There's too much in the synapse. It's not being stored in the vesicle, which is where you need it for efficient signal transduction. And you can accumulate so much dopamine in the cytoplasm that it's actually leaking back out via the transporter. So we call these reverse transport. So there's a reverse transport of dopamine back out. So you still end up with a big boost of dopamine in the synapse, but it's not like cocaine. The amphetamines have gone inside, they've caused the vesicle to be leaky. The cytoplasm is filled with the drug and now leaks back out. So something like methamphetamine is a very powerful drug of abuse because it's such a hard hit. People get really addicted very quickly. But you can see they're quite different. One is non-transported, and this would be the same as your SSRIs or your SNRIs. We wouldn't want it to be transported, really. Because when this happens, you can see it's completely different than the ones that are substrates and causing reverse transport or efflux. So long-term effects of methamphetamine, it becomes very dangerous and neurotoxic because methamphetamine actually accumulates in the neurons. And so sadly, some of those people that are recovery is so hard because at the same time you have done permanent damage to the neurons, that neuronal population, and to other any cell that's got a transporter, really. Because there's a long-term effect, and people are actively studying that because this is some of the problems with methamphetamine, that it's causing this long-term damage, neurotoxicity. But that's kind of the basic takeaway difference between the two. So I'll stop there. These tables coming next look scary, but really not. We're just showing you all the different formulations. So thank you, and I'll see you tomorrow. Thanks.
Yeah.